Post-SSRI sexual dysfunction, or PSSD, is a condition that has stumped many in the medical community. Some may even call it controversial, but for many patients, it has been nothing short of devastating. PSSD is a debilitating condition that severely affects quality of life. We still don't know enough about it. Various theories have been proposed to explain the pathophysiology of this condition. However, there remains a lot to be discovered. The diagnosis of PSSD is usually made by ruling out all other causes, medical and psychological causes. Treatment continues to remain challenging, with no specific treatments identified for this condition. Today, we'll be tackling this critical topic and understanding more about this condition through insights derived from PFS, which is post-finasteride syndrome. Stay with me until the end of the video, where we look at the overlaps in pathophysiologies between PFS and PSSD, and then move towards the potential treatment avenues available. So let's get started. Welcome to Psychiatry Simplified. I'm Dr. Sunil Rege, consultant psychiatrist. If you'd like to explore the world of neuroscience, psychiatry, and mental health, then this is the channel for you. Don't forget to hit the subscribe button to stay in touch with all our future releases. Before we go deeper into these conditions, don't forget to check out this video here where I've covered PSSD in more detail. So let's start off with post-finasteride syndrome, or PFS. What are the medications that are involved in PFS? We have medications such as finasteride, also known as Propecia or Proscar, and dutasteride, also known as Avodart. Now, these are primarily used to treat benign prostatic hyperplasia and androgenetic alopecia, hair loss. So how do these medications act? They act primarily by inhibiting the 5-alpha reductase enzyme. What this enzyme does is it's responsible for the conversion of testosterone into dihydrotestosterone, or DHT. DHT is a more potent androgen. Finasteride selectively inhibits type 2 of this enzyme, whilst dutasteride inhibits both type 1 and type 2. Despite their efficacy in treating BPH, or benign prostatic hyperplasia, and androgenetic alopecia, they come with sexual side effects. These include decreased libido, erectile dysfunction, and ejaculation disorders. Now, just like post-SSRI sexual dysfunction, which can persist even after the medication stopped, with finasteride and dutasteride, the same thing can happen. Even after cessation of finasteride and dutasteride, these sexual side effects can persist, leading to the condition known as PFS. Now, evidence suggests that dutasteride and finasteride can affect both the central and the peripheral nervous system. And the sexual side effects that are associated include decreased or loss of libido, erectile dysfunction, testicular atrophy, and orgasmic disorders. These symptoms can sometimes be associated or accompanied by psychological changes, such as depression, anxiety, and cognitive disturbances. Now, as we go through this, I'd like you to think about these specific sexual side effects and psychological side effects and link them to what happens in post-SSRI sexual dysfunction. So if we look at sexual dysfunction in a bit more detail, we find that some studies have shown that patients frequently report low libido, erectile dysfunction, decreased arousal, and these adverse effects did not resolve in most individuals even after 9 to 16 months of stopping the medication. Physical symptoms include gynecomastia, reported in almost 70% of cases, diminished semen volume and force, testicular atrophy, and genital numbness or paresthesia. The cognitive side effects include mental cloudiness or brain fog, difficulty in concentration, and general memory issues. The study by Ganza et al. 2015 showed that 75% of patients reported brain fog and cognitive disturbances. The same study showed elevated anxiety in 74% of cases, depression, irritability, and suicidal ideation in 63% of cases. So clearly, these psychological complaints were deemed as severe and persistent. Patients also complained of muscle spasms, chronic fatigue, joint pain, muscle aches, and symptoms such as dizziness. The range of symptoms tells us that these medications affect both the brain and the periphery. And it's not completely surprising because it involves hormones, and we know that hormonal receptors are present and distributed all over the body and brain. So let's explore the mechanisms behind PFS. And here I'm going to cover 5 main postulated mechanisms. First, the neuroactive steroid levels. We know that finasteride and dutasteride reduces dihydrotestosterone and increases testosterone and androstenedione. And it does this through the inhibition of the 5-alpha reductase enzyme. PFS patients also showed lower allopregnanolone. Now, allopregnanolone is a neuroactive steroid, and this particular neurosteroid plays a prominent role in both sexual function, but also regulation of mood. In fact, neurosteroids such as zuranolone and brexanolone have been approved for the treatment of postpartum depression and are showing promise in a range of mood disorders. So one postulated mechanism of PFS is linked to the changes in neuroactive steroid level. 2. Androgen receptor upregulation. Now, finasteride and dutasteride increases the upregulation of androgen receptors, and there may be some genetic polymorphisms that may be linked to the risk, which means that in some individuals there may be a genetic predisposition towards the development of PFS. Number 3, gene expression changes. In PFS patients, there are 1,446 genes that are overexpressed and 2,318 genes are underexpressed in penile skin. This, of course, raises the question, is the genital numbness and anesthesia that individuals experience linked to these gene expression changes? 4. Epigenetic modifications. PFS patients seem to show increased DNA methylation in a specific gene promoter in the CSF, affecting gene expression and PFS symptoms. And number 5, the gut-brain axis. Now, this is really interesting because finasteride affects the gut microbiome, reducing its diversity in PFS patients. This change may be linked to both the depressive symptomatology, while the gut-brain axis has been shown to be important for sexual function. This is the first time this is being raised in relation to PFS. So to summarize, we can see that post-finasteride syndrome can result in persistent sexual dysfunction even after the medication ceased. And again, the pathophysiology is not clear-cut. There are some postulated mechanisms, as we saw, linked to gut-brain axis, the changes in neurosteroid levels, and genetic polymorphisms as well. With that in mind, let's now move towards PSSD, or post-SSRI sexual dysfunction, and explore that with the insights that we've learned about PFS. PSSD, like PFS, is a condition where sexual dysfunction persists even after cessation of the selective serotonin reuptake inhibitors. Now, I've covered the mechanisms of SSRIs in more detail in the video here, so do check that out to learn more about these medications. I've also covered PSSD, as I mentioned before here, but it may be worth looking at this video here about SSRIs and emotional blunting, because there is a strong correlation between emotional blunting and sexual dysfunction. There are a range of treatment options available to treat sexual dysfunction induced by SSRIs. What we're talking about in this video is post-SSRI sexual dysfunction, where by definition the sexual side effects persist, and it's a condition defined after a number of other psychological and medical causes are ruled out, treated, and despite all of that, the sexual side effects persist. That is what we're going to dig deeper into. So what are the sexual side effects that persist after discontinuation of the drug? First, decreased libido and sex drive. A significant number of patients report a sustained decrease in sexual desire even after stopping the medication. 2, weak or non-pleasurable orgasms. Many patients experience weak orgasms or a lack of pleasure during orgasm, which can severely, of course, affect the quality of life. 3rd, genital anesthesia. Very similar to what we saw in PFS. This symptom is characterized by a loss of sensation in the genital area, making sexual activity less enjoyable or even distressing. 4. Erectile dysfunction. Persistent erectile dysfunction has also been reported. Number 5. A lack of connection between the brain and the genitals. Some studies have described it where patients describe a disconnect between their sexual thoughts and physical arousal, indicating a deeper neurobiological issue. Now, let's explore the postulated mechanisms. Once again, this video isn't all exhaustive because I've covered many of these aspects in this video here, so don't forget to check that one out. The aim of this video is to look at the overlaps between the two and to see what potential treatments may be on the horizon for these two conditions. So coming back to the mechanisms of PSSD, first, the postulated mechanism of serotonergic inhibition of dopamine release. We know that dopamine plays a crucial role in libido, reward, and sexual function. It is crucial for sexual motivation and behavior. SSRIs reduce dopamine in the ventral striatum, also known as nucleus accumbens, the reward center. And it is this mechanism that contributes to both emotional blunting and sexual dysfunction. 2. Neurotoxicity and genetic predisposition. Just like with PFS, there may be a genetic vulnerability towards developing PSSD. For example, polymorphisms in genes related to the glutamatergic system have been linked to decreased libido and difficulties in achieving erections and orgasms in patients treated with citalopram. This is from the study by Perlis et al. 2009. Additionally, serotonin neurotoxicity has also been postulated, similar to what happens with MDMA ecstasy. Number 3, endocrine abnormalities. Endocrine changes such as low serum levels of gonadotropins and testosterone, along with elevated levels of prolactin, have been observed in depressed patients treated with SSRIs. Now we know that SSRIs can reduce dopamine, and dopamine has an inverse relationship with prolactin. So this may act potentially to increase prolactin levels. These abnormalities are often worse in patients specifically reporting sexual problems, indicating a potential hormonal imbalance contributing to PSSD. So clinically, it becomes really relevant to carry out a detailed hormonal evaluation, including measuring not only serum testosterone, but serum prolactin. And we often find that this serum prolactin can be reversed when dopaminergic agents are considered in the treatment of depression. 4. Epigenetic mechanisms. Epigenetic modifications such as DNA methylation have been observed with chronic SSRI exposure. This differential methylation in individuals may point towards some individuals having a greater propensity again to develop PSSD. Number 5, changes in neuroactive steroid levels, just like we saw in PFS. We know that SSRIs affect levels of neurosteroids. In fact, this is one of the postulated mechanisms that provides benefits in the treatment of depression and anxiety as well. It is possible that these changes in neurosteroid levels in certain individuals results in side effects, particularly the PSSD. Unfortunately, what we don't know is which of these individuals are at risk based on specific biomarkers. Number 6, the gut-brain axis. Just like finasteride and dutasteride, SSRIs also influence the gut microbiome, which we know influences the gut-brain axis, influencing mood, sexual behavior, anxiety, and other psychological aspects. We know that alterations in gut microbiome have been seen with SSRI treatment, and these changes can affect gut steroid production and contribute to an inflammatory environment, potentially linking gut health to PSSD. So what we can see here is that PSSD, just like PFS, also involves a combination of neurosteroid changes, epigenetic changes, genetic polymorphisms, and changes in the gut-brain axis. Let's now look at what are the shared mechanisms for both PFS and PSSD. And the basis for this is based on this latest update from this paper here. And the reason why we want to look at these commonalities is because they can potentially help us understand what are the potential treatments that can address both of these conditions. Because clearly from a pathophysiological point of view, there seems to be an overlap. So the first overlapping mechanism is sex steroids and neurotransmitters. So let's start off with dopamine. Dopamine plays a crucial role in sexual behavior, sexual motivation, erection, ejaculation, and the reward system. The dopaminergic neurons in the brain are regulated by sex steroids such as testosterone and its more potent form, dihydrotestosterone. We know that in PFS and PSSD, alterations in sex steroid levels can disrupt dopamine pathways, leading to sexual dysfunction. For example, we know that testosterone influences dopamine release in the medial preoptic area through nitric oxide synthase. And we know that nitric oxide is the main non-neurotransmitter mediator of penile erection. The second overlapping mechanism is the serotonergic impact on dopamine. Now, serotonin generally has an inhibitory impact on sexual function. In the dorsal raphe nucleus, where serotonergic neurons are situated, we know that serotonin's influence on sexual behavior is modulated by sex steroids. So estrogens here act directly via estrogen receptors, while androgens like testosterone and dihydrotestosterone act indirectly. The inhibitory action of serotonin on dopamine is likely an important factor in sexual dysfunction. Number 3, the noradrenaline-adrenaline balance, or the norepinephrine-epinephrine balance. Studies have shown that finasteride and SSRI, specifically paroxetine, can inhibit the enzyme PNMT, which converts noradrenaline to adrenaline. So what happens here is that there is an excess of noradrenaline. We know that noradrenaline can impact on male sexual function, as norepinephrine induces the flaccid state of the penis, whilst epinephrine or adrenaline levels correlate with erection. This is really interesting because we can see that in the context of anxiety as well, there is elevated noradrenaline, and this can often be associated with sexual dysfunction or performance anxiety, resulting in difficulty achieving an erection. Number 4, the gut-brain axis. Both PFS and PSSD involve alterations in the gut microbiome, resulting in gut dysbiosis. So changes in the gut microbiome affect the gut-brain axis, which in turn can influence sexual behavior. For example, in the context of depression or anxiety, sexual function is affected. So gut-brain axis may act as a mediator, contributing to sexual dysfunction and mood abnormalities. So the big question is, what can we do about it? Whilst of course a lot more research is needed, knowing these pathophysiologies actually provides a potential path for the development of treatments to address these devastating conditions. So let's explore some of these possibilities. First, neuroactive steroid therapy. We know that allopregnanolone is a neuroactive steroid that influences both mood and sexual function, and we know that zuranolone and brexanolone have been approved for the treatment of postpartum depression, which is essentially a mood disorder. So interestingly, one potential treatment option is the use of neuroactive steroids like allopregnanolone, Allo-P as it's called at times. You see, Allo-P has anti-inflammatory properties, and the way it acts is through the GABA-A receptors. It is a positive allosteric modulator. Positive allosteric modulation enhances the effect of GABA on these receptors. So it's almost like GABA on steroids. You see, the advantage here is that it reduces anxiety, reduces arousal, but interestingly, we saw that the noradrenergic potentiation is linked to penile flaccidity. So therefore, by modulating or reducing anxiety arousal levels and reducing noradrenergic potentiation, one may improve sexual function. So that's a really promising avenue. Furthermore, we know that Allo-P treatment can counteract gut inflammation induced by finasteride withdrawal, suggesting its potential use in PFS and PSSD. Again, noradrenaline may feature here because we know that excess noradrenaline increases gut inflammation as well. Number 2, modulation of the gut microbiome. Targeting the gut microbiome through probiotics or microbiome-derived bioproducts could help restore healthy gut flora and alleviate symptoms. Essentially, the strategy here is to improve gut health to reduce gut inflammation, which we saw feeds into sexual function and mood. The third avenue is dopamine agonists. Since dopamine plays a crucial role in sexual behavior, dopamine agonists might be explored as a potential treatment option. These medications could help normalize dopamine function and improve sexual motivation and performance. We already know that dopaminergic potentiators are used in the treatment of SSRI-induced sexual dysfunction. For example, bupropion. Bupropion is known to reverse SSRI-induced sexual dysfunction. Of course, here as a reminder, we're talking about the persistent sexual dysfunction after an SSRI is stopped, which tends to be different in individuals. Similarly, we have agents such as agomelatine and vortioxetine, which again have dopaminergic potentiation properties. Number 4, epigenetic modulators. Given the role of epigenetic changes that we talked about, medications that modify these epigenetic markers may be beneficial. For example, medications that inhibit DNA methylation may reverse the epigenetic modifications that are associated with PFS and PSSD. Number 5, hormone replacement therapy. HRT to correct imbalances we know is something that we use in perimenopausal depression, for example. We know that HRT can improve sexual function. Therefore, this approach could help address some of these hormonal dysfunctions that we've just explored in PSSD as well. So amongst the treatments that I've just talked about, none of these are conclusively established as treatments for PFS or PSSD. There is a lot that we don't know about this condition. However, we can see certain connections being made and certain possibilities, certain agents that can be implemented in clinical practice after a risk-benefit analysis with your doctor. For example, we know that dopamine agonists such as bupropion are available. One always has to consider risk-benefit analysis at an individual level as to whether this is suitable. So to summarize, we can see that PFS and PSSD are complex and multifaceted conditions. We can see that understanding their respective pathophysiologies and their overlaps opens the door to potential treatments, some that are testable in clinical practice. From neuroactive steroid therapy to modulation of the gut microbiome, these seem to be really promising avenues for future research and treatment development. So I hope that you found this video useful. If you liked the video, please leave us a like. Don't forget to subscribe to our channel to stay in touch with all the future releases. And of course, don't forget to leave your comments below. I learn a lot from all of you. I'd like to thank you all for supporting this channel. It means a lot to us. I look forward to seeing you in another video soon. Until then, stay curious. Bye-bye.